Welcome to this clinical lecture on beta thalassemia. I'm Dr. Asha. Today we will see the genetics, pathophysiology, and diagnosis of this complex disease. For a stable functional red blood cell to form, normal adult hemoglobin A requires a perfectly balanced 1:1 ratio of alpha and beta globin chains. Beta thalassemia is fundamentally a genetic blood disorder caused by quantitative deficiency in globin chains. So, how does the quantitative deficiency in globin chains arise? The beta globin gene is located on chromosomal 11. Mutations in this gene causes beta thalassemia. There are over 200 distinct point mutations in chromosome 11 which can cause beta thalassemia, which can be broadly classified as transcription mutations, mRNA processing defects, and mRNA translation defects. Let us explore the pathophysiology. The primary insult in beta thalassemia is not simply the lack of hemoglobin. The true danger is the highly toxic relative excess of free alpha globin chains. We will see how the toxic excess of alpha chains result in anemia. The globin chain imbalance leads to precipitation of free alpha chains. These precipitates undergo oxidation, releasing free iron that catalyzes severe reactive oxygen species damage. This inflicts massive membrane damage and triggers premature apoptosis, programmed cell death, right inside the bone marrow. This premature death of the erythroid precursors is the absolute hallmark of the disease and clinically termed as ineffective erythropoiesis. Remember the sequence: alpha accumulates, causes apoptosis, and leads to anemia. The genetic diversity gives us wide clinical spectrum reflected by the patient's dependence on blood transfusion. At the mildest end, we have minor or trait form representing the heterozygous carrier who are usually asymptomatic. In the middle, it is non transfusion dependent thalassemia or thalassemia intermediate. These patients typically present around the age of 2 and suffer from specific chronic complications like leg ulcers, pulmonary hypertension, and thromboembolic events. At the most severe end is the transfusion dependent thalassemia or thalassemia major. So remember the mnemonic major month 8 onset. Why 8 months? Because humans are protected in utero and shortly after birth by fetal hemoglobin. Around 6 to 8 months of age, the fetal hemoglobin naturally declines and the body has to produce hemoglobin A. But since the beta chains are absent, they are not able to produce the adult hemoglobin, leading to severe anemia. Ultimately, the severe anemia is driven by two simultaneous failures: decreased red cell production in the marrow as well as premature red cell destruction in the spleen. So, the emphasis follows the following mechanism. To desperately compensate for this profound anemia, the kidney pumps out erythropoietin, sending the bone marrow into a hyperdrive mode. The marrow expands up to 15 to 30 times its normal volume. This intense physical expansion pushes against the inner walls of the bones, widening the medullary space and causing severe skeletal deformities such as classic hair on end skull appearance and chipmunk facial features. To compensate for severe anemia, the bone marrow expands massively, leading to erythroid hyperplasia. When the expanded marrow still cannot meet the demand for oxygen, the liver and spleen attempt to resume their fetal roles in the blood production. A process is known as extramedullary hematopoiesis. This results in massive hepatomegaly and splenomegaly. How do we detect this in the laboratory? A complete blood count will reveal low hemoglobin, low mean corpuscular volume, and low mean corpuscular hemoglobin. The peripheral blood smear provides a hallmark clues. We see microcytic hypochromic cells and we see target cells, which have the bullseye appearance due to the membrane excess. I have already discussed this in target cell video that because of the decrease in volume, there is a relative increase in surface area. That is the main reason for formation of target cells in thalassemia. There will be anisocytosis and poikilocytosis, and there will be excess nucleated RBCs, which are immature cells pushed out of the failing marrow too early into the peripheral blood. To quickly differentiate beta thalassemia trait from iron deficiency anemia, they both will be presenting with microcytosis. We use Mendoza index, which is calculated by like MCV divided by RBC count. A score less than 13 strongly suggests thalassemia because the body is making many tiny empty cells, keeping the RBC count relatively normal or high, and a score greater than 13 suggests iron deficiency anemia. For a definitive diagnosis, we use hemoglobin pattern analysis via HPLC or electrophoresis, followed by DNA analysis. Elevated HbA2, that is usually 3.5 to 7%, is a diagnostic hallmark for the heterozygous trait. In homozygous beta 0, the patient, you will see a complete absence of adult hemoglobin A with HbF, that is fetal hemoglobin, is massively elevated up to 93 to 97%. So we can see for the diagnosis of thalassemia, the RBC indices will show microcytic hypochromic cells, MCV and MCH is very low. HPLC will show elevated HbF, fetal hemoglobin is elevated up to 97%. Peripheral smear shows microcytic hypochromic cells, target cells, and nucleated RBCs. A definitive diagnosis and prenatal prediction requires exact DNA mutation analysis. So let us see the few questions to see how much we have understood this topic. First question, which of the following describes the most common genetic basis for the development of beta thalassemia? Reciprocal translocation between chromosome 11 and 16 is wrong. Large deletions on chromosome 16, that is responsible for alpha thalassemia. Trisomy of long arm of chromosome 11 is wrong. So C is the correct answer. Point mutations or the short insertions or deletion on chromosome 11 leads to beta thalassemia. Second question, in the pathophysiology of beta thalassemia, what is the primary molecular drive for ineffective erythropoiesis within the bone marrow? B option, aggressive phagocytosis by splenic macrophages, no. Deficiency of iron for chemosynthesis, no. Large deletions on chromosome 16, no. So answer is A, precipitation of unpaired alpha globin chains. They are toxic and they only are responsible for destruction of the marrow cells, that is leading to ineffective erythropoiesis. Third question, a patient presents with microcytic hypochromic anemia. Which of the following findings for Mendoza index would be most strongly suggest a diagnosis of thalassemia rather than iron deficiency anemia? A value that correlates with high total iron binding capacity? No. B, index that normalizes following a 3-month course of iron supplementation? No. A calculated value greater than 13. A value greater than 13 indicates iron deficiency anemia. So value less than 13. So D is the option. A calculated value less than 13 indicates strongly suggests thalassemia trait. Fourth question, a patient with thalassemia major exhibits crew-cut appearance on the skull X-ray and chipmunk faces. What is the underlying cause for these skeletal deformities? Vitamin A deficiency resulting from secondary hyperparathyroidism? No. Chronic inflammation leading to localized osteoblastic activity? No. Deposition of excess iron within the diploic space of skull? No. So answer is massive expansion of bone marrow to compensate for the chronic anemia. A is the answer. That's the end of this video. Thank you.